little thing on orthodontics here, because to me, orthodontics is the fundamental for restorative in many, many patients. The father of orthodontics, his name was Norman Kingsley. Norman Kingsley was an artist, a sculptor. He went by his eye. The father of modern orthodontics is Dr. Angle, Edward Angle. But Angle orthodontics is built on class 1, class 2, class 3 relationships. Why? Because they had to be reproducible to be able to be taught in dental schools. You had to have a standard for teaching. But not everybody fits into the box. Not everybody fits into what's called Procrustean treatment planning, where everybody fits into the same thing. Sometimes you have to revisit the fundamentals of beauty, like Norman Kingsley said, to come up with a proper treatment plan. Angle orthodontics, just by going by class 1s, by class 2s, by class 3, sometimes it's produced results that don't look very good. You know, would Barbara Streisand look better if she had her nose fixed? I'm not so sure. Can anybody improve on Bob Martin? So sure. You know, you have to go with your vision, not just by what the ideal tells you. Not everything fits into the box. Our success in doing aesthetic dentistry is based on how well we examine, how well we treatment plan, and how well we present the treatment plan. And of course, you have to deliver. To treatment plan a case, you have to be able to see the end result before you start. Then compare it with the current condition. If it doesn't look, if what you have now doesn't look like what you want at the end, you got to say to yourself, how do I make what I have today look like what I want? The face dictates the treatment. This is known as facially generated treatment planning. Every case today is planned aesthetically. And you always reference the patient's maxillary tooth position and the gingival levels before you start anything. Do I have to change the position of the upper front teeth? Once you know where your upper front teeth are, you can establish all the occlusal issues, and you can have your final vision of aesthetics, create your vertical position, your pathways of guidance, and your edge-to-edge position. Aesthetic dictates your final vision. It doesn't mean that you're going to do aesthetics first, but aesthetics is going to show you where to go. If we look at this girl, this is a simple case. To treatment plan the case, we take photos, we look at her face. Is there enough tooth showing? According to a study by Vigan Brundo, that at 30 years old, you should be showing about 3.5 millimeters of tooth. She shows enough tooth. We don't have to lengthen the teeth. We draw in the midline. Midline is fine. We draw in the upper tooth position. We could restore the teeth in this position. We draw in the laterals. We can restore the teeth in those positions. We draw in the canines. We can restore the teeth in those positions. This is a simple aesthetic case where nothing has to be changed. We do a diagnostic wax up. We do templates, guides, all the techniques that are taught in every course. We do our provisionals, follow the provisionals or you die, and we get a gorgeous case, predictable. But if you can't draw the lines over the teeth, you have to do something different. Maybe you either have to compromise your treatment or you got to do orthodontics. This is another girl. We draw in her teeth, draw in the midline, draw in where her central should be. Uh-oh, we can't do teeth in that position. This is where our laterals have to be. We explain it to the patient. Oh, do you want your teeth to be perfect? She says, yeah. I say, you need ortho. I show her a picture of my wife, which is basically the opposite case. We do orthodontics. We bring it together, temporize, provisionals, follow the provisionals or you die. Final case. I'll just go quickly through a few more because this is all interdisciplinary cases built on aesthetic vision. Patient, extreme wear in the front teeth, looking very, very difficult. Well, what we did in this case, we drew the teeth. We did a diagnostic wax up. We did orthodontics to intrude the teeth, to open the dimension, to create more space. We continue to take x-rays. Once we saw that the roots started to blunt, we decided to stop. We pushed enough. We did a periodontal surgery. We did crown elongation on the lower, temporized. Same thing on the upper, temporized. Final temps, preps, follow the provisional. Final case. I'm not here to show you guys techniques. There are courses and courses and programs to learn all these techniques. I'm here to show you a philosophy. Once we know where the upper teeth are, all we have to know is where the lower teeth have to be. Why? Because the lower teeth are really the upper teeth. Lower arch discrepancies result in deviations in the incisal and in the occlusal plane. So once you know where your upper teeth are, you look at your lowers. Are your lower arch in proper alignment to accommodate what you want to do on the upper arch? If not, you have to redesign and temporize your lower arch. So let's just go quickly because we're almost out of time. This is a typical patient that walks into any of our practices. This lady has her teeth. Her dentist says, your teeth are fine. You're grinding your teeth. I want to make you a guard. This lady says, something is wrong with me. I don't like my teeth. I find that they're getting shorter. They're sensitive. And you could see that she had lower molar extractions when she was younger. And what happened over the years, she basically wore herself into her own occlusion. And as teeth wear, the tooth position changes, the gingival levels change, the papilla change, the tooth display decreases, the anterior smile line goes into a reverse curve, and your centrals and laterals become more square. So what we decided to do in this case is we decided to do orthodontics. If you look at her teeth, they're chipped, they're cracked, there's sensitivities, there's super eruptions, the occlusal plane is not in line, there's lingual wear to the upper front teeth. We fix the foundation, we do lower ortho. Of course, everybody in their 50s, like my wife, wants bigger, sexier front teeth. And we space out her teeth. Towards the end of orthodontics, we place 4 anterior provisionals so we can visualize that we're in the right place. And then we deband the patient, prep the front 6, lux attempt provisionals, follow the provisional or you die, copy the provisional. These are felspathic porcelain, recreating the lingual surface of the teeth, and our final case. And this is what we do every single day. And I want to leave some time for any questions. So I would just like to thank everybody. And I just want to promote our meeting that everybody is welcome.
I've always said, if I can do it, you can do it as well. I see that my prophecy has come true. Who owns the face? We do. And we proved it. And the whole world knows it. God bless all of you.
So Erwin Smigel created the ASDA in 1976. And this man practiced until he was 90 with that sparkle in his eye every single day. He was super generous with his knowledge. He always had a kind word for everybody. You bless you. It was always about you. Who owns the face? We do. If I can do it, you could do it too. So the ASDA, the American Society for Dental Aesthetics, it includes dentists from all the specialties. And because of people like Dr. Smigel and Dr. Dawson and all the courses I took over the years, I knew I had to establish a complete team, an interdisciplinary team in my office where I was in control and we all have the same vision, philosophy, and goals. So who owns the face? We do. And everybody, you're all welcome to come to our meeting. It's the most fun meeting in dentistry. Leave your egos at the door. And so far, we're still on for this year because we have high hopes, guys.
Yeah. Elliot, that was outstanding. Okay, I got to ask you the question. Do you have T-shirts that say, follow the provisional or you die. Because if not, we're getting them printed.
No, but you may, I have many lines that I made up, reduodontics. You may use any of them.
That is the line of the day. I love that.
Well,
I also love the would you want to buy a cheap parachute? I wrote that one down. That's a great one. I usually say, it's like your bald tires on your car. Like, are you going to drive around in bald tires? But I like this better.
Well, I flew through the cases because I wanted to show a lot, but it wasn't about how to do the cases, because to do some of these cases, it takes a lot of experience and a lot of education, and there are programs for that. And there's the COIS program, the Spheres program, there's Dawson, there's Pankey. We ran a program at the University of Toronto that I had Bob on that program. We were running the aesthetic continuum. I just wanted to show everybody a different way of thinking, an interdisciplinary approach.
Elliot, I've never heard you speak. I've heard about you for years. One of the coolest things, I think, is you're giving young dentists permission to be the quarterback. And that's one of the greatest messages today, is that for us not to be afraid of doing our own homework and research and being able to speak up and partner with our specialists. So what a joy to hear you. Thank you.
You're welcome. Thanks a million. And remember, there are patients.
Elliot, I enjoyed that very much. You have a great way of explaining things, making it simple. And I appreciate you taking the time to come on today. And I look forward to seeing you at the ASDA meeting.
Mm-hmm.
Great.
Yeah.
And now we're going to hear Joyce, who actually talks faster than I do.
She's the best.
Yeah.
Elliot, go back to your guitar now.
That's what I'm going to do. But actually, I'm going to watch Joyce.
I thought you were going to serenade us.
Well, hey, one of these days, Elliot, when it's safe to travel again, you're going to host something at the cathedral that you've been talking. What is it called again?
Elliot.
Yes.
The studio is, yeah.
You've been there. Wouldn't that be a great place to have a party?
It'd be awesome.
We've had many parties there over the years.
Outstanding. Well, good stuff. Well, Elliot, I really appreciate that. AB, do you want to keep rolling? Do you want to take a break? What do you want to do here? Or
yeah, we can take a couple minute break. That way we can get everything switched over. And yeah. Sounds good.
What if we do this? We've been running and gunning on such an aggressive schedule. Let's just take like a 2-minute break just so we can refresh, and then we'll come back and we'll get rolling with Joyce. Sound
Excellent.
Good?
Sounds good.
Thanks, guys.
Thank you.
Really great to see you, Elliot.
Oh, thanks. Great to see you too. It's been a long time, Scott.
Yeah, for sure.
I'm hiding up in Mont Tremblant.
Yeah, that's a gorgeous spot. People need to go there.
It's a good one.
Hi,
Joyce.
how are you?
Great, Joyce. How you doing?
I want to double check to share. Hey, I love you. How are you? Good
Joyce
morning.
and I are BFFs now.
I love him.
We love Joyce, my wife and I.
Oh, and I love you back.
You look
Does she
great.
not have the coolest
I've been
artwork?
on. I did my hair first time in about a month. I mean, I've been wearing sweats the whole time.
I love
Yoga clothes, Lululemon and me, number one.
Oh, now you're for sure AB's BFF.
Right. And I'm so intrigued by her artwork. It's
Yeah, I got my beautiful man that comes out of the wall. In the
Cool.
my sculpture.
my kind of girl. If you want to go ahead and practice to
Can we
share,
do
Joyce,
this
that way we
just so I can see where it's at.
Yeah.
Okay, so wait, now I have to go here. And then, okay. So
Do you
now
see the little green at the
This
bottom?
at
The
the
start
bottom?
sheet? Uh-huh. There you go.
then I have to move it over and then I hit play. I'm not going to hit play till I move it over. Is that okay?
Is that your first slide that you
This
want to
is my
start
first
with?
slide.
Okay.
Is that good?
Perfect.
Perfect. So that's me. All right, now how do I go back?
You could move it
You can
over.
leave it there,
if you want to.
yeah.
You could go ahead and play.
Yeah.
And then we could just keep that up until you're ready to go.
Can I? And then I just have to hit the button?
Yeah.
Yep.
There you
All
go.
right, thank you.
Awesome.
And you can
Okay, so I can just start like this and I don't have to do anything but hit the buttons.
Yeah.
Oh, make my day, because that's my
Okay.
biggest loss. How does the volume sound?
Very
I don't
good.
think we are loud enough, Joyce.
Do I need to be louder?
I'm kidding. You're killing it, girl.
How are you?
How are you?
Good to see you too. All right, so I don't have to be so loud, which is good because I was hearing my microphone. So
this will be a first.
That I'm not loud?
I don't think you need a microphone.
Ritter goes, you need a separate microphone. I go, I don't have a separate microphone. He goes, well, your voice may not carry. Well, I'll have to tell him it does.
It sounds good.
We're going to have fun today. That's
yes,
right.
Hey, Joycey.
Yeah.
How you doing?
Good. How are you, Dan?
Good. It's warmed up out there since you and I last talked.
Degrees. It's killing COVID. COVID is dead here. It's 100 degrees.
Send some back to Ohio.
It's terrible. You know.
Joyce, I'm so excited to have you on. We are so excited to have you on.
Hi, Kirk.
How are you?
Good. Thank you for having me.
Oh, it is our pleasure. Thank you guys for doing this.
Yes.
And I know you've got a ton to share. I always love our great presenters and experts to get a great introduction so that everybody knows why they should be paying attention. Mm-hmm. Who will give us the honor of introducing this fantastic presenter?
I'd be happy to do it, Kirk.
All right, Dan, take it away, buddy.
All right. I had to introduce Joycey because she's a graduate of the Ohio State University. So that speaks volumes about her credentials. She's an accredited fellow. She's a past president of the American Academy of Cosmetic Dentistry. She's an associate member of the AAED, a COIS clinical instructor, a member of the Academy of Fixed Prosthodontics, a fellow in the AGD. She's on the faculty at his Arizona School of Dentistry, an active member of Catapult, and active with the Give Back a Smile program. She practices in Scottsdale, Arizona. You know, Elliot was talking about music, and I was thinking of Joyce. To the musicians here, Joyce only works at one tempo. Presto, 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 babachi, faster, faster, faster. Joycey, take it away.
Okay. Hi, everyone. From Scottsdale, Arizona. And we're all dentists. And when we look at an image or a person, where do our eyes go? Since we're dentists, most of us look nose to chin and we look straight at the teeth. And what we look for is what's wrong, what dentistry has been performed. So we look at a one-to-one view consistently, and we look at the incisal translucency. Which one isn't the same? Which one's more opaque? How is the gingival scale up? What tooth is fake? So today we're going to look at where's your eye going when we look at these restorations. So this patient presented with an unsightly composite on the right lateral incisor and a congenitally missing tooth on the other side. Never in her wildest dreams did she think with just 2 restorations, she could look like this. It was a great day in the office. Sadly, it's never always been like that. We have restorations today between porcelain veneers and zirconia that are really aesthetic. So now we can really blend these restorations in with the natural dentition. But for me, it took me 7 times at the AACD that I flunked before I passed. And so I learned a lot about failure and how to stop failures and how to train my eye. Because before, all I was doing was looking, but I didn't really see. And I had to train my eye to see and to focus. Because if I couldn't see it, then I can't do it. So what about here? Let's train our eyes for the next hour. Where does your eye go? What do you see? Do you see that crack on that right side? Well, we fabricated a composite restoration on the other tooth. And our goal with the stratification technique is imperceptible dentistry and a happy patient. We also want longevity and predictability because the longer we practice, the more if something goes wrong, it comes back in your face. And we have to have a cookbook, easy protocols and systems that we follow. But what about this restoration? I started by taking x-rays when it had the impression analog in, and then I watched the bone after we put the restoration in, and over the next 8 years, we lost bone. And I'm sitting there thinking, oh my gosh, what happened? I thought I did everything right. You know, I use the analog. I put the cement on the crown, put it on the analog. Then I place that in the mouth and in the tooth. And then I use a really good cement. so that it's not supposed to get on the root. But then I looked at it and I go, it was a screw-retained restoration. So it wasn't even because that occurred. I mean, it was screw-retained. So I'm thinking about my failures. And I'm thinking material, function, or execution. What's going on? Why are they failing? And I keep thinking, what am I doing wrong? But not anymore. Now I'm thinking, what am I learning? And how do I share information with everyone? Today is what I'm going to do as much as I can, because you can always tell an experienced dentist. They know everything, right? You just can't tell him or her anything. So for today, please don't find the one thing that you don't like that I'm going to say and shut me out. Stay with me through the presentation, because we're going to look at real world cosmetic dentistry, the faults that occur, how do they fail, and how do we fix them? Because we're going to look at dental facial failures, digital smile design, how do we utilize this so we do not have as many failures, and how do we look at bite and function so we don't have failures? We want to avoid failures. When we go to the Siri and go, hey Siri, what's the definition of cosmetic? Siri says it's a superficial measure to make something appear better or more attractive. It's a decoration of the smile. So a grill is cosmetic dentistry. And that case on the right of your screen is a case that I did, and it's very white, monochromatic, no color gradation, kind of piano key-like, and it's very media generated. And that is a little more cosmetic dentistry. Now, how do I get the patients to choose the white that they want when we're going to have these restorations performed? I don't want to have toilet bowl white, but some of them want toilet bowl white. So who is my patient and how white are they? And I don't have any value judgment toward them. It's their choice. So I look at the color of their eye and I compare it with the color of the teeth. And that's your aesthetic diagnosis. The teeth should not be whiter than the sclera of the eye. And if it is, it doesn't look good. It looks worse. While I'm up there with that shade tab, because color is patient-driven, I'm looking at their eyelashes. When I see their eyelashes and it looks like they're spider webs and they've got those fake eyelashes going on, then I'm thinking a cosmetic patient. Then I'm looking at their lips. And if the lips have a lot of fillers and they look like that, and I can't get cotton rolls in or room lock trays, I'm thinking a cosmetic patient. The first thing I'll do with our patients, and I will whiten them. And I'll try to get them as white as they think they should be. But if they choose after that to have some veneers made, I'll look at these pictures and I'll go, what color do you think you want to be when you have your veneers? They go, I don't know, doc, I'm not sure. I go, okay, what do you think? The patients that choose one, I use Luxatemp Bleach 1. And then I use that color because I believe that color is the closest to the 1. If they like a 2, then I go with the Pro V from Bisco. If they want a 3, they pick the 3. Then I'm looking at the Ivoclar. So I have all of these composite provisional restorations in my practice so I can start with the color I think they need to have. I make them stain it. I have them drink wine or cigars, coffee, tea. And then every couple days they come in and we take a picture with the shade tab till they find the color that they like. And then that color I'll take a picture and send it to the ceramist. This is the final body color that we would like. Now we take the glaze and put it over the top once we know what color they want, and we seal that color in so that they can wear that. And again, this is a Luxa glaze that comes from DMG product. Now the patients that choose this really white, usually the toilet bowl white, it's going to be an HTBL1. If they like closer to a 2, then I'll usually use an HTBL2 ingot. But you also have to look at how dark is the stump. Because if you really need to block the stump out, you're going to use an M ingot and you have to layer it. Now, when you use layering porcelains, it's 100 megapascals. So you have to be careful how you layer your porcelains because those layering porcelains can chip. The old-fashioned way was to cut back and then put the feldspathic everywhere. The new way that we're doing, because we want 500 megapascals of strength on the incisal edge. That's where the load is. And so now we're layering only the facial and leaving that area there for strength. Because if you really want strength, you just want to stand in glaze and do everything on the top and try not to layer it off. Now there's new materials out there. There's zirconias that are translucent. They're getting more beautiful. So if you do full coverage restorations, these can range from 650 to 1500 megapascals. And there's a new product out right now by Ivoclar that has gradient technology, and they have all 3 layers in the same puck. It comes out in 1 layer, and then that's called prime. And I'm utilizing that for all my anterior bridges now. It's very beautiful. Now, what if a patient, you don't know? So you can ask a patient a question. Do you want to look like you used to look? Or do you want to look like you never looked? And if they want to look like they never looked, they're more of a cosmetic patient. They're going to give you the selfies. They're going to be monochromatic, whiter kind of teeth when you're done. Then there's patients, I couldn't even get a normal general, just a plain old denture in her mouth. I couldn't get it right, the setup. So I had to ask her, what do you want to look like? And she wanted to look like she used to look, not like she never looked. So then I would get an historical picture, and then I would take that picture, look at it, and then set the front teeth up in the denture in a manner that she liked. So now 8 and 9 are more protrusive than when I was setting it up. So I utilize all of this technology and all of these systems for everybody, even single tooth or fillings. So you don't have to just be doing 20 veneers. Now, if I went to Siri and said, what is the definition of aesthetics? Siri would tell me it's the nature of beauty. We're not inventing anything new. We are just copying something that we think is perfect. So here's cosmetic dentistry on the left, which is very media-driven, perfect. Then aesthetic dentistry on the right is a tetracycline case where he chose the same shape and form just to be one, color gradation. So it's natural. So those patients are more aesthetic dentistry. So I believe it's important that we figure out what category our patient is in so we can design our restorations in that manner to not have a failure. So what about here? Where does your eye go? What dentistry has been performed? This patient has veneers on the top and natural teeth on the lower with a little bit of composite. But when she came to me, she looked like this. And she goes, Doc, I want some veneers. And I'm like, okay, but we need to really do a treatment plan and diagnosis. Diagnosis is knowing what to do and knowing when to do it. And this comes from the Coy Center. So you don't just jump in ever. You really have to stop with these patients, take pictures, and do a functional occlusal and cosmetic diagnosis. So dental facial treatment planning is combining everything with function. So you do not want failures in occlusion, in dental facial, no failures. So you have to go slow in the beginning. So when you evaluate her bite, you could see that the lower teeth on the arch form weren't even, and then she has a parafunctional habit. So if you build her case in the same place, she's going to break it. It's going to happen to you. So it's important that we have to explain to them that where her teeth are in the face are wrong. The teeth are okay. They need to be moved. Your face, it's got to be moved. And the first step always in dental facial treatment planning is the maxillary incisal edge position. But also the first step in anterior guidance is a maxillary incisal edge position. So I'm always looking at the front tooth and I'm putting that tooth in the face. So you evaluate that tooth, and this is a supplementary tracing from a lateral perspective, and you can see the tooth is wrong. Now, just because they don't want ortho doesn't mean they're not going to get ortho. It's just harder to get them to do it. So what I have to do now is really show them the technology. And in Sure Smile technology and with TADs, we can put them on the lingual and move those teeth up. So these patients that are older that don't want to show orthodontic brackets, we can utilize this technology. Now, this patient had these original veneers placed, and the dentist that was before me just put them on because she had all these diastemas. So it was kind of worked in my advantage because she needed to have these teeth moved up and back in her face. And so by doing that, we had to do interproximal reduction. So I utilized the 8x10 rule and the golden rule of proportion, and I thinned out each tooth so that we can move them together and up. And by doing this, it really removed the porcelain in the interproximal areas. Now, when I was ready to place my veneers, I'm going to always utilize a wax up. And if not, if she wants to be right where she is, we have incisal reduction guides, labial reduction guides, and a provisional matrix. So we want to utilize this technology. We will have failures. But in this case, because we move the teeth together and up, You can see here that it's not a no prep. I think Marge talks about this. It's less prep. And it's enamel based because of this. Now, I'm going to utilize my technique of what color do you want? Do you want them whiter on the top? I guess she has a high smile line on the top, but a low on the bottom. And I'm going to utilize a B1 from Luxatemp as my provisional restoration. And then I'm going to ask her to stain them with her coffee, her tea, whatever she'd like. And then she's going to get to the A1. And in her case, she liked it darker. She didn't want the whiter veneers, and that's what she chose. So she went closer to the A1. Then we're going to analyze the shape and the contours of the composite prototypes to see exactly what are you looking for. Do you like the shapes that we have? So she wears them. My patients always go, I don't know what to do. And I go, well, you can have round, round. You can have square, round. You can have square, square. You have all these different shapes. And they go, I don't know. You're going to have to tell me what to do. I go, no, no, no. You're going to help me, because what I'm going to do is make composite provisionals in your face and change them a little. And then you can start looking yourself. So we look at a fake fingernail, and I go, look at my fake fingernail. It's fake. It's very cosmetic, and it's square, square. Then there's a patient in Flagstaff. The right side of my screen I can't see, sorry, so sometimes I'll forget. And she has a natural looking. It's rounder on the edge. I go, so we will take your composite provisionals. I'm going to make them different on the edges. And so on one side, I'll make them square and longer. So you'll see 7 is longer. And on the other side, I'm going to start opening up the contacts. Now you can utilize this with 2 teeth, 4 teeth, or 6 teeth. So it doesn't have to just be a big case. So then the patient is going to look in the mirror, go home, and then she's going to look right and left to decide what side she likes. Then we can look at the outline forms. Let's say I make them different a little bit, and one's more square and one's more round. And she can choose what side she likes, or he. And then I can use flowable composite. Again, I'm using a beautiful from Show Food. And then I'm going to make it thinner or fatter on the other side. Try to get them to be the same. I never get them to be the same. But I tell them I'm going to get them close enough, because then the ceramist is going to help us, because she's going to fix everything I do. All we need is one really good tooth, and she will make the other tooth match. And this is called the art of customization. When I'm doing this, the patient owns the aesthetic revolution. She knows what she wants, and she's going to get exactly what she wants, because she designed it. So no one's going to come to her and say, I don't like this. I wish I would have done that, because she designed it in her face. Now, when we're looking at this, and we're going to get into this with shape and form, teeth have different shapes. You can make an ovoid tooth. You can make a square tooth, depending on these line angles. And you can make a triangular tooth. So when you have your wax up from your digital design, you can design whatever way you think, but you can change it in the composite prototypes so the patient can see different shapes a little bit at the gum line with flowable composite. Once they decide, then you can take an impression and send it to the ceramist. Now, this is where they get to go home, and they get to look in the mirror. I say, go to your husband, go to your significant other, your family. Do you like one side more than the other? And pick the side you like, or the tooth that you like, so you can help design. That way they don't come back and go, I don't like this on the corner. I don't like this. And that's what they do otherwise. And they make you an Arabic Majnooni crazy. And we don't like that. So now they're going to own it by utilizing these techniques. They always ask me, when am I going to get my teeth? And I always say to them, when are you going to sign off? Because I don't know how long it's going to be. My ceramist, I have a date with her for the provisional restorations, but I never know. I can't push them, because if they don't sign off and they don't own it, we're in trouble. I have flow sheets and systems. They sign off on the temporaries or the provisionals, and they also sign off on the personal. That way, they own it, and they can't come back, right? Yeah, they still do. So same color in this case. She decided she wanted the uppers and the lowers to be the same. So that's written in there with the shade tabs. Now, these are the flow sheets that I use, my customized laboratory prescriptions. And I'll take the 2 fingers and put them between 7 and 10, so she only sees 8 and 9. And they're close, but they're not the same. And I go, which tooth do you like better? Then my prescription will say, patient likes outline form of 9, the left. Please make 8 match 9 in everything, if she wants them the same. Then 7 and 10. Sometimes 7, she'll want different than 10. So I'll say in the prescription, my patient wants them a little different. not a lot, but a little. Use the edges, but you can round the corners. So I designed to that level with the patient, and this is how the prescription is, and it gets emailed to the ceramist so that she knows what to do. Then there's color. So how do we pick the color? This is my MAC room. This is my consultation room. So I have them sit there from the beginning. We always go back in and they look at pictures. They sit side by side. They look at these photographs and they pick the final color from, like we talked earlier, but the surface texture. They look at different teeth. The one they like, I pick it out and put it in Dropbox. The surface incisal translucency, the one I like, I pick it up, put it in Dropbox, and they pick the images. So the ceramist has an idea of exactly how much texture, how much on the edge. Otherwise, they go, oh, I don't like this little corner here. I don't like that. So they choose it, and then she has a guide, and it really helps a lot. Now, this patient chose a perfect match from top to bottom, signs off on everything. I followed all my systems and protocols. I thought, okay, I'm a winner. It looks so good, right? So she comes back to get her guards and her Essex retainers because she was post-ortho, and she wasn't happy. And then I'm like, okay, just wear them a little longer. We'll see what's happening. You know, she comes back the next time. She's kind of crying. So I'm sitting there thinking, I utilized all my techniques. It still doesn't work. What's good to know is that if you place a little bit of staining on the teeth, then you could possibly take the stain away. Because the problem with communication is no matter what we do, I think it's occurred. And it doesn't always occur because they always change their mind. A lot of them change their mind. So you want to have systems that you can at least keep working together. So in this case, she wanted it whiter. So when you utilize a yellow bracelet diamond, I always say Parkinson's disease. So you don't want to just take all the stain away. You do want to just go boom, do-do-doom, do-do-doom. Just really like a feather edge going across the top. Then you need to polish it. And I use the Shofu polishing paste because it's really not a fail if you can get some of those colors up because of the stain being there. And then I polish it really good so that you still have the same luster as you started with the case. Now, she's closer to a B1. She's got most of the stain on. And now I have a happy patient. She's happy.